go to the patient in the ward or in OPD, what happens is that you must see how he's coming to you. What is his attitude? Some people will be brought to you when you grow up as doctors, medical officers, emergency medical officers. They will be brought in stretcher, and somebody is accompanying, and the patient is unable to talk to you. So therefore, you have to see who is bringing him and what is his attitude. Is he able to speak? You cannot take history of a patient who cannot speak. He is injured, he is unconscious, and he is helpless. He is totally in the hands of others. You get my mind? So therefore, this is history taking is an art, and you have to make it whenever he is brought with person, he is injured. You have to make a diagnosis what is wrong, which part of the body is, and you have to allow priority to that patient. He may be having head injury, chest injury, he may have fractures, he may have abdominal injury. So you have to examine him in detail, and if he is unable to talk to you, nobody is there, you have to give a focused attention to him. And therefore, you have to allow priority. You have to allow, if a person has got a minor fracture, you will not attend to him first his fracture. What is killing him is the abdominal bleed. You have to find out, is he bleeding, because internal bleeding is not revealed. So therefore, it is for you to decide what is killing him, what is the priority, which organ should be tackled first, whether it is the brain which requires brain and injury there, whether the chest injury that requires, which is it may be immediately life-threatening. So therefore, to have, for this to achieve that standard, you have to have an experience. And experience will never come unless you watch your seniors how they are working and you have knowledge of the subject. So therefore, the first and foremost duty of a student is to read and read. If we do not read in our profession, we will be killing patients, because treating a patient without knowledge is very, very harmful, right? So therefore, I'll start off. The first thing you do whenever a patient comes who is able to talk to you, you have to take a proper history, right? And before you do that, you have to ask what is his name, which place he belongs to, what is his occupation, what is his gender, right? This will give you an idea about, there are certain diseases which are related to age, and there are certain diseases which are related to occupation, the trade. The first and foremost thing is, the first point in history taking is, after a brief introspection and seeing his attitude and getting a little bit of idea about his background, chief complaints is the first major thing you will go through. Chief complaints. What are the chief complaints of the patient? And second one, thereafter comes the history of present illness, where I have elaborated. History of present illness. And thereafter comes history of past illness. There comes history of personal and social history, right? Then comes family history, and you will also include any history of medication in the past. Thereafter comes, after you have obtained sufficient history about the patient, and he is not a very serious condition, because your history will change from a chronic patient, his attention which is given to him is different from a person who's having an emergency because of trauma, where his life is in danger. Then you cannot waste your time on history taking only. You have to simultaneously gain what are the findings, what is the brief history, and immediately you have done some kind of a primary survey, and thereafter you examine the patient. So thereafter you come in a normal patient, next point is general physical examination. general physical examination. Then comes your systemic examination. After you have done this, you will come to some conclusion that what is the disease the patient is suffering from. You have taken the history, you have done the general physical examination, you have done the systemic examination. Now you have something in your mind. Yes, this is the problem. This is called provisional diagnosis. You have made a diagnosis provisionally, which is to be confirmed by investigations. Then you do relevant, specific investigation, which should not be out of the context, and it should be focused. Most focused investigations you have to ask which are relevant and will lead to the diagnosis. And after that you come to a diagnosis. After you come to the diagnosis, then the treatment starts. Okay? More serious a patient, there's a life-threatening emergency, then your approach to the patient will change. Now let us focus, because you are the beginners. So, chief complaints. What are the chief complaints? Firstly, remember that once you ask the patient something, it should not be in technical terms and medical terms. He will not understand. Okay? You have got, say, vasculitis. He will not understand what is vasculitis. You will ask in a plain and simple language, what is your problem? Is it pain? Is it a fever? Is it swelling somewhere? So that, if you tell him, have you got pain? Have you got a swelling? This is a leading question. You are giving a line to hold on that. Yes. But you have to ask him in a language which he understands, and his own language you have to ask him. Chief complaints. That suppose he has got a pain, he has got a fever, he has got a swelling. So you record not many chief complaints, 2 or 3 complaints. Okay? In chronological order. Chronological order means the symptomatology which happened first, that is to be recorded first. Suppose the person had pain in the chest, 3 months, fever 2 months. So the first complaint which will record is pain which is occurred first. Thereafter, subsequently you will record pain, fever, swelling. So in that order, that sequence. This is called chronological order, and these are the chief complaints, the major complaints the patient is having in his own language, and record his chief complaints in his language and what he says. Thereafter comes the next is history of present illness. That means now whatever he has said that he has got a pain, now you have to go after the pain or the fever in details. The first thing you will ask, when did if it is pain anywhere in the body, you ask him, when did the pain start? When did the pain start? Or whatever is the disease, when did it start? And then you will ask, did it start all of a sudden? Or it started off gradually, slowly? Is that right? Then how was the progress of it? What is the kind of pain? In his own language, it is mild pain, it is a moderate kind of pain, or it is a very severe pain. History of present is not talking about. Okay? And then you have to ask what increases the pain, what relieves the pain, what time it comes, right? So this is the history of present illness. There are so many types of pain. The character, you have to know the character of the pain. Then you have to ask what are they. Then you have to ask him what else. If he says, well, I've got fever, then you a pain generally is into what? It is into either injury or a trauma or a fever or some kind of involvement of the nerves in any of the diseases. Alright? So if it is fever, then you will ask him, when did the fever start? How often it comes? Is it constant fever? Does it become normal also? Does it come every day? Or it comes on alternate days? Does it come after taking some medicine? Alright? Yeah. So this is the history of present illness. Then you have to ask the patient the history of present illness. What is the complaint? No doubt about it. Then normal biological features like how is his appetite? If his appetite is good, perfectly all right, probably, that these not having any kind of a GI problem. Then you ask, how are his bowels? Is there any urinary complaint? How does he sleep? Is his sleep is disturbed? Alright. So all these things you have to record in a manner of his language. Thereafter comes history of past illness. In history of past illness, you will ask the patient, did the patient suffer from any disease for which he was admitted in the past? Alright? Or any disease he had in childhood, like rheumatic fever or rheumatic heart disease thereafter. So, history of past illness, like most times, majority of the diseases are, which are, related to childhood, which are some diseases are of congenital origin, which are there right from the birth. There are certain diseases which a person acquires as a young person. There are certain diseases which a person gets in old age. So, but you must take history of number one. Diabetes is number one. Diabetes. You must take history of diabetes. Number two, whether he had suffered from hypertension. Any history of myocardial infarction, which are related to heart, any history of rheumatic heart disease. In our country, you must take history of whether the patient has sometimes in his life suffered from tuberculosis. Then you must ask him, now the things are a little different. In our time, previously, people used to contract so many illnesses which are transmitted from contact, sexually transmitted diseases. You must take history of these diseases, right? Whatever it is. And any history of, a person who is a frequent traveler to one place to another and things like that. People who come from other countries, in our country, other geography and, topography and climatic conditions are quite different from many other countries in the northern hemisphere. So these tourists and travelers, when they go from one place to the other, that place may be having, hot, humid climate and maybe, a lot of mosquitoes and filariasis and things like that. Mosquito and insect-borne diseases and things like that. So you must take history of, whether the person has traveled to any other country where malaria is there, filariasis is there, some viral disease, things like that. Then comes your history of social and personal history. Social and personal history. Social and personal history, straight away ask the patient. Patient was, is he vegetarian or non-vegetarian? His diet, what does he eat and how much he eats? Diet is very, very important. It has got a direct relationship with the health of an individual. If a person is taking healthy, clean, good diet, that means the person is unlikely to have diseases related to a food which one should not eat. So therefore, you should ask him, are you vegetarian? Are you non-vegetarian? If I am non-vegetarian, what you are eating? If you are a vegetarian, what do you eat? Because many people who are vegetarians, he may not be taking full content of what he is getting from the non-vegetarian food. And there are the proteins, right? So even a vegetarian, you will have an idea. The person should be taking good amount of carbohydrates, fats, protein, vitamins, minerals and things like that. Vegetarian food has got its own advantage. There are so many advantages of vegetarian food. There are certain diseases which are associated with God only knows that if you are taking non-vegetarian food, perfectly sterile and sanitized and whatever you call it, but you do not know what kind of a disease that animal has been suffering or suffers from, chopped off and cooked and fried and things like that. Whether a person takes a good amount of salad, is he taking a fresh food? There are certain foods which you take will cause malignancy, cancer, carcinoma of the large gut. It is conceptualized as person because high protein diet, dense diet, animal protein stays in the gut for a longer time. The transit time of the animal proteins, animal food, is longer. And therefore, this has got a longer contact with colonic mucosa. So these are the candidates who might suffer from carcinoma. And there are certain diets, nutritions, something like these what you call spicy and very hot food and pickles and stale food. It contains nitrosamines. So therefore, they are also candidates for GI or GI malignancies. So you must find out. And on the other hand, a vegetarian may be taking a rice and potato, therefore he lacks in nutrition, so he'll be malnourished chap and more prone to get certain diseases which you may call he's a immunocompromised candidate, right? So another thing which you have now, this is the that you have asked, and second reason you ask the easiest smoker because smoking is a very common pet habit these days, right? Smoking. What does he smoke? Does he smoke bidi? Bidi. Smoking is a very dangerous thing. It causes all kinds of diseases, right from head to foot. It may promote cardiovascular diseases. Person is more prone to coronary thrombosis who is a smoker, right? Person may have peripheral vascular disease, which is called Burgess disease. What is it called? The peripheral circulation of a person who is a heavy smoker can suffer. He can have. There's a patchy inflammation of the vessels, of all kinds of vessels, arteries and veins and things like that. This is called thromboangiitis obliterans. I'm just giving you the names also. What is it called? Thromboangiitis obliterans. It's a patchy inflammation of the vessels and they become narrowed and ultimately the poor feet and digits, they are the most distant part, from a good blood supply. So you'll find ulcers on the feet and things like that. We'll discuss it later on. This is called Burgess disease. I'm telling you the bad effects. It may cause other types of cancers also, right? A smoker may have lung cancer, a chronic smoker, smoking 80 cigarettes a day, 10 packets of beads. It may cause carcinoma of the lung. All those people who have lung cancer, more than 90% of them have been smokers. Is that right? Lung becomes black. Then comes your alcohol. Now, as far as smoking is concerned, you have a smoking index, pack index. If I smoke 20 cigarettes a day for the last 10 years, so my smoke index is 200, right? And more than 300 is dangerous to the life. That's similar to the pack index also. Pack index means how many packets of cigarettes I am smoking daily for years. Suppose I am smoking, I am consuming 2 packets of cigarettes a day for the last 2 years, so my pack index will be, I'm smoking 20 cigarettes a day. Okay? Pack index, how many packets of cigarettes you are smoking for 10 years? So, if I am smoking 2 packets for the last 10 years, my pack index is 20. Right? Dangerous situation. Then comes your alcohol, the dreaded thing. No, alcohol consumption is bad for health in any quantity. Even it's a CNS depressant. It may cause gastritis. It may cause cirrhosis. You get my point? So drinking alcohol can cause gastric upset. It may cause gastritis. It may cause liver damage. It means the CNS depressant also. And if it is not a standardized alcoholic drink, if the country-made liquor, it can create havoc. It may be adulterated also. It might contain methyl alcohol also. That also gives a kick to the patient which they enjoy. They make them blind and they might lose their lives. Then in social and personal history, you must take history of habits of the person. Is he a sportsman? Is he a traveler? right? So these kind of things you have to ask. You also have to ask the patient when you go to the family, when you go to the community medicine, you will be visiting families. You will be visiting families in the villages also and cities also. How they are living, how many people are living, what are their nutritional status and things like that. Then comes your family history. In family history, what are you going to ask? The patient, the disease from which a person is suffering. Has it been there in some family members? They are certain people are living together. Some people are living together. In one room there will be 10 chaps. So if one person has got a tuberculosis, he will communicate this disease. This is a communicable disease. It's called communicable disease. So others also might get tuberculosis in the open cases of tuberculosis, right? Then you have to ask, is there any family history of, suppose a person comes with lump breast, I'm using the word person comes with a lump breast, any swelling in the body anywhere, particularly in the breast, in elderly group otherwise mostly, it should be considered as malignancy unless proved otherwise. It has to be proven that it is not malignancy, right? There are certain words which you will not understand on sensitivity and specificity. Suffice to know, you have to take a proper family history, whether mother, father, grandmother, sister, they have suffered from disease, mother and the father, brother and the sister. They are first degree relatives. What are they called? The chances are acquiring, getting through the genes is quite high. So you have to ask the patient, is there anybody in your family who has suffered from this disease or has suffered from some disease along the lives, things like that, right? This is briefly I told you the history table. Now let's come to general physical examination. General physical examination. General physical examination, the patient comes to you. What do you see in a patient? What do you see? The first and foremost, 3 words will settle so many problems for you. What will you ask? Is he conscious? Is he oriented? Is he coherent? What did I say? I'm talking to you now, you can make out, and you are before me, so I am fully conscious. Am I right? Am I talking sense? I'm taking your class, so I'm talking on a history table. I'm not talking anything of dramatics or something like that. Am I conscious? Am I oriented where I am, where the patient is, and coherent? Is he talking sense? Right? Then his attitude. If the patient is lying in the bed and he is unresponsive, or he is sitting in a chair, how he has come to you. How is next point will come is how is his belt? Your eyes will perceive, all the senses should be working. It should be perfect coordination. Right? Well, the patient is poorly built and poorly nourished, that you will examine. So you have to see, you have to write in your notes. This is now general physical examination is your observation. Now the patient cannot tell you in general physical examination I have a swelling, which is a carcinoma of so and so thing, right? Or your sebaceous cyst. No, it's not his job. You have to observe. It is for you to decide. So therefore, what you do is now you observe the patient, whether he is well built, a person who is well built, muscular. He is called a mesomorphic personality. What is it called? Mesomorphic. Have you heard this word before? No. Mesomorphic means he is well built. Ectomorphic. A thin kind of individual. He eats halal a lot, but he is still thin. His metabolic rate is very high. He may be having thyrotoxicosis, hypothyroidism, because metabolic rate is high, their appetite is increased, there's fatigue, they are in tension, they are in anxiety. You have to see the patient's makeup also. How is the patient? How is built? Ectomorphic. Then is endomorphic. Endomorphic. What is endomorphic? A fellow who's who is sitting, eating, munching, watching television, and lying on the bed perpetually. He has not spent enough amount of money, and he just doesn't go out. I've seen people who would just have lunch and dinner and then come to the bed and watch television. There's nothing else to do. They enjoy that kind of life. So they are obese because of the lifestyle. So that is, one is ectomorphic, another is endomorphic, another one is mesomorphic. Alright? Mesomorphic personality, person who is obese, it may be because of other causes, also maybe having obesity. So therefore, you have also to see his body mass index, BMI. Have you heard about it? You must have been told in medicine. What is it? What is body mass index?
Basic metabolic rate of
Weight.
basic metabolic rate of basal metabolic rate.
Okay, got it. Body mass index is different. Body mass index means weight of the patient divided by height in meters squared. A person whose body mass index should be between 18.9 to 24.9 is that you can say to somehow, yes, okay, acceptable. But less than that, 18.9 or 18.4 or 5, that makes it underweight, is a candidate for, must be some nutritional problem. So a person who is nutritionally not taking enough diet and food is not available to him, or he is having some problem with GIT, esophageal won't be eating, right? So these people will be undernourished. One is a person doesn't get food, or is not able to swallow the food, or it's not available to him, right? A person whose body mass index is say from 25 to 29.9 is overweight. And above 30 you can say safely that obesity. And then if he's, he requires a crane to go out of the room, and he cannot go out of this room, he can confine to the room, people is so bad he can't go out unless the door is broken. So these people get candidates, you can call some morbid obesity and super obesity. There are all type of people in this world, right? So you have to see. And how do you see for nutritional status? Whether a person is anemic or not, that of course is the mid-arm circumference you have to see. Mid-arm circumference, number one, and triceps full thickness, skin thickness. Okay? Tell you a rough idea about the nutritional status. Now, thereafter, in general physical examination, what points you will see? Now, these are the points we should go and see in the ward, right? What do you see? Anemia, pallor. Pallor will see that person is not having anemia, iron deficiency, which can happen due to diseases also, which can be due to blood loss also, which can be due to nutritional problems. Yes, there are hereditary disorders also. So you have to examine the patient for what is that? Pallor. And how do you see through the pallor? You see the palpebral conjunctiva. You ask the patient to look up and see the palpebral. This is the palpebral conjunctiva. It should be fairly muscular and it should be red. If it is pale, that means person is maybe having anemia. And you can see the ear lobule. Okay, for this thing. You can see the nail bed. You see it should be red. You see the palmar crease. This is red. You look at my hand. I am not anemic because there is no hair. My nail bed circulation is good and capillary return is good. So therefore, it is red. The red color comes back after you are rested, and then leave your finger like this. Pressure. You release your pressure. So then under surface of the tongue, get up the tongue, right? You can make out, right? Then comes your, one is failure, Then you have to see cyanosis. Cyanosis, bluish discoloration, that means there is deoxygenation somewhere. The person is having either some kind of a respiratory disorder or some cardiovascular problem, and it may be some kind of a, you must have heard about this thing, carbon monoxide poisoning and things like that. The color changes into a different areas. Cyanosis. Then you have to see whether it's a central cyanosis or a peripheral cyanosis, right? Then comes your jaundice. How do you see jaundice means? A yellowish discoloration. There are so many diseases in which a person can have jaundice, particularly pertaining to liver. It may be hepatitis, it may be malignancy, it may be secondaries, carcinoma is somewhere else, and the metastasis, the disease has spread to the liver. So, where do you see? Again, you see the sclera. Sclera. You ask the patient. You ask the patient to look up and push the eyelids up, and if the color of sclera is yellowish, it may be due to jaundice. Then what you see, color of the skin also at times you can make out. Then the tongue also, under surface of the tongue you see that, right? After that we have discussed the spella and we have discussed the jaundice. Then comes your pulse rate. Pulse rate is a versatile investigation, basic examination. Pulse rate. Normal pulse rate of an adult is 72 to 80 per minute. You see the pulse. Where you see the pulse? The most common site is the radial pulse. Radial pulse is seen when you palpate with your three fingers, the ring finger, the middle finger, the index finger. Each finger has got its own job. You press the artery, radial artery, against the underlying bone. Which is the underlying bone? Radius, lower end of the radius, radial spine, in our bone, right? This is the lower end of the radius. You press the artery, radial artery, with three fingers, the index finger, the middle finger, and the ring finger, which can tell you what is the tension, what is the volume, what is the retrograde flow, what the condition of the arterial wall. In an elderly person, the radial artery will be thick, right? Next pulse will be, what is the rate? Rate is 72 to 80 per minute. It may be less than 60. If the pulse rate is less than 60, then what is it called? It's called bradycardia. It is called bradycardia. This may happen. A person, see the water investigation. You put a hand on his pulse and his heart rate is 40. You immediately come to some conclusion in your mind that it may be due to heart block. Heart block. And heart block, there's so many kinds of heart block. There will be something wrong with the sinusoidal node. The sinus bradycardia or sixth sinus syndrome, which you will read later on. Okay? So the heart rate, some of the athletes were good sportsmen. In my life, personally, I'll quote you my example. I was a very, very active sportsman. I was used to work, only two things I did in my life. Work very, very hard and play a lot of games. So athletes, they have bradycardia. Any heart rate which is less than 60 per minute is called bradycardia. It can also happen in certain diseases like I told you, cardiac disorders. It may happen due to hypothyroidism also. Hypothyroidism. That enough of a thyroid hormone is not being secreted by the thyroid gland. By the way, tell me, where is the thyroid gland? Where is it located? Yes, it's the thyroid gland. Yes, of course, in front of the neck on both sides. The two lobes. Anyway, this is, once you go up in class, then of course you study about thyroid disorders also. So, hypothyroidism, if it's not functioning properly, thyroid hormones not being secreted. This use was a very common practice in those places, in the mountains and the hills and things like that, where there is a deficiency of iodine. So iodine is the major source for the deficiencies of thyroid hormones, T3, T4, and things like that. right? So hypothyroid, people who are eating, some kind of food which are do not permit trapping of this thing, the iodine, and may cause hypothyroidism. And it is one may acquire hypothyroidism through the genetics also. And there are certain disorders like Hashimoto's disease. Just remember, you might remember it again. Hashimoto's disease, which can ultimately result in hypothyroidism and bradycardia. Then there are disorders like, even typhoid fever. Sometimes the heart rate will go down. Then comes your tachycardia. Tachycardia means heart rate is, you can say, more than 80 or it is 90. So heart rate which is more than the normal, say about 90 or so, it is called tachycardia. Tachycardia may occur in so many diseases. And what are the diseases? In fever there may be tachycardia. In hyperthyroidism there may be tachycardia. In cardiac failure there may be tachycardia. Tachycardia may occur after injury because of the blood loss. But a person has lost, is dehydrated due to climatic vomiting, loose motion. The person is dehydrated. He has lost a lot of fluids and electrolytes, right? Then when the blood volume goes down, so body, the important organs of the body, they require what? Brain requires oxygen and glucose. And there is not sufficient amount of oxygen to be provided because of hypovolemia. The person's sensorium will deteriorate, may become unconscious also. So the heart starts compensating for that. Heart is one organ which works for us day and night throughout the life. Right? So all the tachycardia are many, right? So what are those many causes? They are loss of fluid, fever, even pain will cause tachycardia, hyperthyroidism will cause tachycardia, right? And then in pulse you will see, is the pulse regular? I'm stressing on pulse itself. Is it regular or it is irregular? Or the rhythm is not normal, right? What is the volume of the pulse? What is the tension in the vessel wall? Okay, what is the pressure in the thing? And then you see, you compare the right sided radial pulse with the left sided. Sometimes the left side, one of the radial artery pulsation may be absent. You can also see the pulse rate from brachial artery. For that you have to go to the elbow, medial to the tendon of biceps brachii. You can feel the tendon. You see, I done this, and tendon is here. Just medial to it, you see the brachial artery pulsation. You can see the axillary artery pulsation also. Where do you feel the axillary artery pulsation? You feel it in the axilla, not on the medial side. Here you will find the ribs only in the axilla. It's outside. If I am examining it, so the right side I examine with my left hand. If I have to examine the axilla of any person, the right axilla, I cannot move with the right hand. I move with this hand. Okay? So I'll press it like this. Where? This is the right side. So right hand will see the feel for the axillary artery. So suppose this is the arm axilla of the person, this is the lateral wall. So I'll press it against the upper end in the medial surface of the humerus. It's like this. So it's like this, right? If you examine somebody, you find the axillary artery here. You will not find the axillary artery here. You won't find it here. It is at the upper end of the humerus, axillary artery. Then carotid artery, where do you feel? Carotid artery is 5 feet palpate on the medial side of the supramastoid muscle. The transverse process at the tip of the 6th cervical vertebra, right? You can feel it like this. I can feel my carotid artery like this. So you can go to the board and then we can demonstrate. It's just theoretically I'm briefing you. We'll demonstrate all these things on the patient's side. And then if you want to see the subclavian artery, you go behind the patient, dip your fingers to the supraclavicular region and press it against the first rib. Ask the patient to shrug the shoulders, go behind him press it against the bony prominence has to be there. That is the first rib, right? Similarly, we now come down to, you can see the superficial temporal artery also. We come down to femoral artery. Femoral artery, where do you palpate? Yeah, it is somewhere mid-inguinal point. Mid-inguinal point is a line drawn from, if you draw a line from anterior iliac spine to the pubic symphysis, the midpoint of it is called is mid-inguinal point. Midpoint of the inguinal ligament is different. That is not the pubic symphysis, basically the pubic tubercle, right? So there, just 1.25 centimeter below it, you will feel the femoral artery. And if you want to feel next to the popliteal artery, where do you feel? In the popliteal fossa. Ask the patient to lie down on his front and then flex the knee, and the midpoint, middle of the popliteal fossa, you find popliteal artery. You can also feel when the patient tries to find, ask him to flex, and then, your hands, your thumbs are anteriorly, and then once the knee is flexed, you press it in the middle of the popliteal fossa. Then next comes the way you can see the pulsation of the person is the anterior tibial artery. Anterior tibial artery you can feel on the anterior part of the ankle between the medial and lateral malleolus. This anterior tibial artery will go down and become the dorsalis pedis artery. Dorsalis pedis artery, you will feel it dips down. It will feel this artery, you will palpate this artery only in the base of the first and second metatarsal. Between the first and metatarsal, the base, you will feel the dorsalis pedis artery, lateral to the tendon of extensor hallucis longus. What did I say? You can palpate dorsalis pedis artery between the first and second metatarsal artery, lateral to the tendon of extensor hallucis longus. And then the posterior tibial artery, you press it over the medial malleolus. This stuff from the medial malleolus to the tip of the calcaneum. You draw a line. It is a junction of 1/3 and the lateral 2/3. You just press it. Dip your finger over the medial malleolus and press it against the bone. The artery will feel the posterior tibial artery. Now this is about pulse. Then in general physical examination, what you see the texture of the person. See his hair also is having alopecia or something like that. So I have mentioned that in general physical examination, you see his build, nourishment, pallor, cyanosis, jaundice, and then we will see whether the person is having edema. Edema is diffuse swelling or a localized swelling in you can feel it in subcutaneous tissue. Edema. That means a person who has got fluid in the interstitial space. If there are certain diseases which can cause edema. Alright? There are certain diseases which cause edema. Edema as a fluid in the interstitial space. And of course it comes from the blood vessels itself. Right? So what are the causes? So how do you see for edema? You can see the edema. You press it against a bone for 10 to 30 seconds with your index finger. Pulse of the distal phalanx of the index finger or even the thumb. Press it over the medial malleolus, over the tibia. You press it like that. And if there is edema, significant edema, the person may be having 2 to 3 liters of fluid in the interstitial space. It has come out. Right? And once you press it for 10 seconds, 20 seconds, 30 seconds, you will find there is an impression and there is a compression. The fluid is driven away and you find a well-like thing. That means there is a fluid which has been displaced into pressure. Right? So what are the conditions in which a person will have edema? Yeah. In hypothyroidism, yes, I do agree. Then Now you touch the point of hypothyroidism. If you go into examination, you were suggesting hypothyroidism. Now the examiner in final exam will catch you on hypothyroidism. He'll ask you what is hypothyroidism, what is the mechanism, what is how the physiology of thyroid gland. So don't get into trouble of leading the patient to a dark side. It's like GPS. It lands you in somewhere in a problem at times. So always direct the examiner towards that point which you know the best. So you'll be centering around that only. He doesn't have much of time. Your device should be to direct the examiner. Even in this, lead him in to a place which you are familiar with. You understand? So edema occurs because of so many. Because edema, besides hypothyroidism, I like to agree with mixed edema and things like that. It can happen in hypothyroidism also. The much more important are other causes of edema. Person may have cardiovascular disorder like congestive cardiac failure or right ventricular failure. Are you aware about it? You need it in physiology also. It may cause edema, cardiac failure, congestive cardiac failure, right ventricular failure. If you know ECG, there will be positive R waves in V1. I am saying you these words because this will make an impact in your mind. You have not read about ECG, but I am saying positive R waves. Now you remember somebody 10 years back, somebody had told us that there can be positive R waves in congestive cardiac failure, right ventricular failure. So edema can occur in congestive cardiac failure because of the back pressure, right? Then edema can also occur in nutritional problems. A person who has got anemia and hypoproteinemia, the fluid goes from low concentration to the high concentration, right? Osmosis. So therefore, a person who is anemic, who is hypoproteinemic, those poor children, who are not enough to eat, so they might have edema. Whole body is swollen up. Anemia and hypoproteinemia. Third thing the person can have edema is cirrhosis of the liver. Cirrhosis of the liver is a fibrosis of the liver. So portal venous stress flow is going out and portal venous pressure increases. So cirrhosis of the liver can also cause edema. And then one of the important organs, it can also happen in renal diseases. Renal diseases can give rise to edema. These are the basically. Now, after edema, we have tackled anemia, cyanosis, jaundice, edema. Comes lymphadenopathy, lymph node enlargement. There are so many causes of lymph node enlargement. Where are the lymph nodes? You have heard about lymph nodes? Lymph nodes are mainly where you can palpate these cervical region, axilla, and inguinal region. So cervical lymphadenopathy, axillary lymphadenopathy, and inguinal lymphadenopathy. What are the causes of lymph node enlargement? May be reactive hyperplasia. It may be infections. It may be metastasis. It may be some kind of a malignancy, hematological malignancies, right? So there are so many causes of lymph node enlargement. Some parasitic disorders also. So anemia, cyanosis, jaundice, edema, lymphadenopathy, and thereafter what you do is you see the skin, bone and joints, see the spine, see the skull, examine the person thoroughly, right? And what else we have to see? In general, you have to see the perineum, genitalia, and things like that, right? So basically, now you will come to a conclusion after you have taken a history, you have the general physical examination, then you go for systemic examination. You have to examine the cardiovascular system, you have to examine the nervous system, you have to examine the skeletal system, you have to examine the vascular system. Okay? There are so many diseases of the vessels which become manifest, like varicose veins and things like that. Now you come to a provisional diagnosis and confirm it with the diagnosis of the specific investment. Thereafter, after the provisional diagnosis, you subject the patient for investigations. Investigations. We have so many investigations. Now, what are the investigations generally? General practice, what we do is, what is?
CT.
Generally, what is the complete blood count? So, as far as examination is concerned, you have to be thorough with the nervous system also. How to see the person has got is the involvement of the motor nerves or the sensory nerves, radial nerves, and things like that. See? And heart, you have to examine the heart. How do you examine the heart? Examination starts with inspection, palpation, right? Inspection. Inspection is what you see in a person, right? If you want to see the heart problem, you see the precordium. You can see that the or anxiety is there. In inspection, you can see the swelling also. Inspection, you can see varicose veins also. So inspection is very important. And in inspection, what do you see? If in abdomen, what do you see? Whether the abdomen is distended or not. What is the condition of the unclitus? Is there any varicosity of veins in the abdominal wall? You can see the pulsation of the abdominal wall. So inspection is basically an examination of a patient, what you see. Then comes your palpation. Palpation, if you see the swelling, then palpation means that you examine with the palmar surface of your hand. Palpation, you examine with the palmar surface of the hand. You appreciate it. And palpation, you may use the fingers also. That examine the palmar surface of the hand, including through the fingers. But one thing, if you want to see palpation, what do you see? You see whether the temperature is raised, whether the swelling is there any tenderness in the abdomen or anywhere. What is tenderness?
Pain.
Patient has already said, I have got pain. Pain is a symptom. What patient says that I have got this problem, that is a symptom. But tenderness means when you press a particular site to the body and patient evokes winces with pain. That means it is tenderness. It is a sign. Right? But temperature, if you want to see if there is a pus anywhere in the body, there is a swelling, it will be warm, it will be hot, that will be tender. Right? This is better appreciated with the dorsum of the hand. This is better. The temperature over the swelling is better appreciated by dorsum of the hand. That is called tenderness, palpation. Then in palpation, what you see? This. If there is a swelling, size, shape, margins, palpation, and then temperature, whether what is the consistency, is it firm, it is hard, it is soft maybe because of, the abscess may be soft, it's a firm, it may be some kind of a fiber, or it's hard, it may be malignancy or things like that. Then comes your percussion. Percussion means you use the dorsum of the middle phalanx of the left hand and percuss with the distal phalanx, tip of the distal phalanx of the middle finger with the right hand. So then you illustrate what is the, if a person has got a new phalanx and you percuss it with your tip of the middle finger, it will be having some kind of a resonant sound. Okay, that kind of thing. In case there is a swelling, it will be have a dull note. It will be having a dull note, right? Then comes your auscultation. For auscultation, what you do is you use your stethoscope. Mainly, we use stethoscope to auscultate the lungs and the heart sounds. There's the first heart sound, second heart sound, third heart sound, fourth heart sound. Take a mitral area, tricuspid area, pulmonary area, and aortic area, right? So after you have done the complete examination, you have a diagnosis, and then you ask for, you are coming back to investigations. Now, I'll give you an idea about the investigation, what all investigations may be required. The investigations are generally done, what organ is involved. Okay? So, investigation, any patient is entitled is a lifetime. So, therefore, patients do not please realize the fact, whenever I say 200 patients a day, even the 200 patients you cannot do the patient is going to be as good as complaint, you have scribbled and dished out the prescription. EMC, you have to be there from morning till night. I have said personally, no posting. But patient should not be denied the right full examination because it's not going to come to you every day. If I'm a surgeon, I'll not check the blood pressure. Why? What's wrong with that? At times a person will drop in your OPD with a surgical swelling. You are not checked up, the blood pressure is gone back. He might be having blood pressure. We've seen whenever I used to sit with the interns and JRs and my professors also, when I was heading a university level postgraduate institute, post-retirement. You have to tell your juniors that please examine the patient to tell it even he has got a cough. Take him to the couch and lie down and examine. You may find something else because for him, it's a once in a lifetime chance to come to the hospital. Please give him a full examination. Maybe you have got 200 patients. You will be emergency, you will be running out of this thing to tackle the emergency. This has happened. Then come back. Keep on munching something there itself. It's just not. If you have got 7 patients, okay, you have good luck. So give the patient a full examination, that's what I'm saying. And investigations also relevant, but today CPA, Consumer Protection Act. The judge will ask you, Doctor, why there was a mild headache, you didn't ask for the CT. Judge doesn't know about investigations. It has happened that you have not done CT. Who does CT but pure, simple, person has got headache and fever and things like that. So therefore you have to balance yourself as far as when you're writing investigations, you have to save your skin also. Because the court, no one is going to protect you. Right? So CBC is the most commonly written investigation, complete blood count. ESR is raised. Now CBC will tell you about state of anemia, whether platelet count and total lymphocyte count. Then you must write down a person who is going to undergo surgery, say after 40 years of age, you ask for blood sugar, fasting and BP also. And a person is already a diabetic, then you will have to ask, what is his HbA1c? So blood sugar. The main investigation we do are depending on the disease, but KFT, kidney function test, blood serum creatinine, serum electrolytes and things like that. Remember, I have told you the investigation which you commonly try because you are putting on the white coat. You go to a home, your brothers, sisters, and relatives will ask you, what all investigation should I undergo for my general checkup? So CBC, ESR, kidney function test, lipid profile, blood sugar, thyroid test, T3, T4, TSH, and anti-thyroid antibodies test, Hashimoto's disease. Okay? Then what are the investigations after 40 years? You have to subject a person to ECG also. ECG. Why not? Yes. And any person who's going to undergo surgery or things like that, subjected to X-ray chest also. Then depending on you have got, what are the investigations? So many of them. One, ultrasound, right? Ultrasound. Then Doppler ultrasound, if you are tackling the blood disorders of the blood vessels. Thereafter, ultrasound is one. Then mammography. All women above 40 must be subjected to mammography every year. Every year. What I'm saying is, all women above 40 years must be subjected to mammography. And in those patients who have family history of malignancy of any age group, they must be subjected to mammography. Then we have another investigation, CT. Computerized tomography. We have got magnetic resonance imaging, MRI. And then, depending on the heart and things like that, you can have angiography, you can have CT angiography. And these are common investigations I'm telling you, that do not ever miss the right urine routine examination. Okay? So these are the basic things which I have told you. Thank you very much. Kindly get me the register.